auscultation after all other. It doesn't matter really, but if you do palpation before auscultation, maybe you change type of peristalsis. Not seriously. If patient has generalized peritonitis and you maybe irritate movements, you start more intensive movements, maybe that happens, but it will not play great role. So you start with auscultation. Auscultation of the abdominal cavity should be done, well, if you are not very experienced, you have to listen at least during 30 seconds in one point. Cold? A little bit. Okay, you make it warmer with your hand. 30 seconds here, for example, 30 seconds here, or you can try every quadrant, but it will not differ a lot. Also with the stethoscope, you can check pulsation of the, not pulsation, auscultation to auscultation of abdominal vessels. Typical positions are abdominal aorta, here, left to the umbilicus. This is a projection of bifurcation. If you join this point with palpable femoral arteries, you also can listen to the femoral arteries on both sides. And if you join this in the middle, this is a projection of the iliac arteries, right and left. Then, subxiphoid area. So you find xiphoid. Here, this is a point for celiac trunk and superior mesenteric artery. If you hear the murmur, you cannot differentiate with your ears. What is it? Celiac trunk or superior mesenteric? You have to do further investigations like ultrasound or angiography. Then, in the middle between umbilicus and xiphoid, middle of the distance, and then you go to the costal arc. This is left renal, this is right renal artery. In the same place, but from the lumbar area, you can also listen to the renal arteries, but layer of muscles is thicker, so sound will go, well, some surgeons prefer that, some prefer this, but if patient has obesity, it's better to do it from the back. If patient is not thick, then it doesn't matter.
And position of patient will be lying? Position, spine position.
For arteries?
Yes, sir.
Yes.
So renal fluids, if renal stenosis is present, it is usually heard at, you said that midline and on both side, or we can heard around.
Stenosis of the renal artery. About stenosis of the artery. You remember that if stenosis is small, so if we have artery and small stenosis, 10, 15, 20%, you will hear nothing. Because this murmur, it's very small. For ultrasound, yes, it's detectable. For your ears, no. If stenosis is critical, like 90%, 95, 99, you will not listen to that also, because blood flow is extremely slow and you hear nothing. Nothing yet or already nothing. If something between, like 70, 60, yes, you will hear this murmur as turbulence. By the way, I don't know if, well, I showed you pulsation of the legs,
Yes.
so you know that. Traditionally, we do not listen to the arteries distally than inguinal ligament. So most distal artery that you can listen to is femoral artery. In the hip, you can listen to, if you find, for example, pulsating mass, that can be a post-traumatic or post-operative aneurysm. You can listen to that. But normal arteries or sclerotic arteries are not auscultated traditionally. And on the neck, also, that is important. You can do auscultation. You see? Sternocleidomastoid muscle. And, okay. you find the angle of the jaw. This is a projection of the carotid artery. And between the clavicle, so half of the clavicle, 4 centimeters above, or you just place big stethoscope between clavicle and between muscle. Here.
Jugular.
JVP.
No. This is vertebral artery. 4 points only, and if you find murmur, you send patient to a neurologist or to ultrasound, and you can save patient from ischemic stroke.
So there is also, we can place stethoscope only 30 seconds.
No.
So how much?
30 seconds for abdominal peristalsis. Because for 30 seconds you can hear 30 sounds. 30 sounds, yes, it's enough. So 30 seconds is too much. If you want to listen it, of course you can do it 30 seconds, but usually doctors are limited in time. So if you find murmur, of course you want to describe it, you listen it longer. But normal picture, you can assess it quickly. Next, with auscultation also, you can check patients' hollow viscous for retention of the content. That occurs in case of stenosis of gastric outlet, pyloric stenosis, and acute intestinal obstruction. You can do it with your hands only. So you place hands like here, but you must be very close to the abdominal wall, like that. Or you can, instead of one hand, you use stethoscope. Okay? So if you find splashing sound, this is a sign of stenosis or intestinal obstruction. But you can listen to that normally. After meal, during 1 hour, 30 minutes, if you drink several glasses of water or eat soup or tea, then you can find it easily. It's normal. But usually when it's pathological, it sounds like metal sound. More deep and splashing, and you find it 3 hours, 6 hours after meal, next day if it is decompensated stenosis.
How do we find the location of duodenum?
We cannot do that. Duodenum is mostly a retroperitoneal organ, so it's not palpable. You cannot do auscultation or percussion of that. No. No chance.
I don't know, somebody told me that if we auscultate, we can by finger. And
okay.
then
This is not duodenum, but you can detect greater curvature of the stomach. Yes, you can do that. Yes, you place stethoscope in the left upper quadrant. Here.
Sir, what we will heard here?
Try.
scratching sound.
अभी इससे साइन पूछ लो सारे इनके कोई.
So you place stethoscope just below costal arc and then listen. It differs. Do you hear that it becomes very low sound,
Yes, here.
and you can find the border. So you do several times. Try it yourself. No, like that.
स्क्रैच कर
Numbers करके ना.
इसको दबा के
And go up and down several times. It becomes very dull when you leave the border of the stomach. Very dull, like far away. Percussion. Percussion of the abdominal cavity. You can do it anywhere. It depends what would you like to find. In some places, you always find the same sound, normally. like here, you find, for example, gas in the stomach. It's more tympanic here. But maybe, okay, we will first detect liver. So it's higher than costal arc here. That's okay, not lower. So, and we go from the lung.
Yeah.
That's it.
A tympanic sound we heard there.
Tympanic usually it's tympanic, it's not high tympanic. My secum sounds better. It's typical. Secum and gas in the stomach. And sometimes, for example, if you are checking patient for appendicitis, and maybe patient says that I have pain here, you quickly need to detect that patient has no reverse of the organs. So maybe heart on the right side, liver on the left side. Sometimes that happens.
Yes.
I have seen that several times. And you need quickly to detect. So you find liver dullness, you find gas in the stomach, so you know that abdominal organs on its place, normal. Or you can do auscultation of the heart also, and you find heartbeats in the left or in the right. With percussion also, you can check peritoneal irritation. You can do it like that. This will be painful. Or with your hand. This is more gentle. In case of severe peritonitis, generalized, maybe use your hand. Not so painful for the patient. Also, you can check presence of free fluid. You go to the flanks from the center. Yes, you find dullness. Then you ask patient to turn a little bit. That's all. Like that. Not like that. Not completely. Because you will lose this border. So a little bit. And wait 20, 30 seconds on the side. On the side, yes, like that. Fluid will collect and this border will elevate. Normally, it will not change. But in case of free fluid, it will go upward. Yes.
Or you can put hand.
Yes. Okay. For detection of ascites, you can use this sign with the hand here, but usually you don't need that because first moment, negative, that you need an assistant for this because you use both of your hands.
Patient can
Try. Not comfortable.
Yes.
And we have young, healthy patient. In case of big ascites, small chest, for example, it's hard for the patient, or patient maybe cannot understand you sometimes. What do you want from him?
Yes.
Or not able to press that because you need some pressure. Not only put hand, but do pressure. And well, try how it looks here. This is fat. If you fulfill, for example, a balloon with water, and try this, it will be more this feeling, you know, this wave by the fat. It goes slowly. In the fluid, it goes immediately, very quickly, and it's more stiff. And in case of ascites, we can see that umbilicus is not inside, it's prolapsing usually. Many patients with ascites will have umbilical hernia.
everted.
And for free fluid in case of trauma, this method is not a method of choice because you need several liters of fluid inside to detect it by fluctuation. You have no so much blood inside. So if you can detect this, patient should be dead. Full abdomen of blood. So you need to do percussion. It's better, it's more sensitive, and in any case of blunt trauma, if you have ability, independently on your percussion, do fast. Focused abdominal sonography for trauma. Right and left hypochondrium, epigastrium for pericardial sac and pelvic. And you find free fluid quickly.
What is Puddle sign? Puddle sign in ascites.
Portal sign?
The,
I don't know.
yes, Puddle sign. PUDDLE.
PU?
Double D.
कैसा होता है दिखाओ?
अब मुझे पता नहीं है ना, मेरे से पढ़ा है.
Pudu.
चलो इससे मुझे ना इसी के साइन
हाँ, क्योंकि यही पूछेगा ना एग्जाम में, तो यही पूछेगा ना.
अरे ascites में होता है यार ये.
अरे यार
For checking for ascites?
Yes.
I don't know. I don't know this name. Maybe I know the sign, but by another name.
Wikipedia.
А как по-другому, как и шумы там साइंस?
Asit?
साइन पूछना है आपने.
Abdominal distension. In cirrhotic patients, you will see visible veins around umbilicus, usually.
Spider AV or spider.
Yeah, like spider. That's all, I think, for free fluid.
Yes.
Or parallel veins visible.
भाई अल्ट्रासाउंड क्यों कर रहा है? सीटी स्कैन डायरेक्ट उसको ना, सीटी स्कैन.
Palpation.
हमारे बड़े सामने रहते हैं.
CT scan महंगी होती है भाई. Palpation planes.
Palpation, okay. Palpation, if you do palpation of the abdominal cavity, remember that first you have to ask patient where he has pain. And you have to start in the opposite side. Most of the surgical diseases are on the right side. Appendicitis, cholecystitis, duodenal ulcer. So traditionally we start from the left iliac.
So this one.
एंटी क्लॉक.
Bottle sign, physical examination maneuver that can be used to detect the presence of ascites. It is useful for detecting small amounts, smallest steps. Patient lies prone.
For 5 minutes.
5 minutes. Patient then rises onto elbows and knees. Applies stethoscope to diaphragm, the most dependent part of the dome. Fix near foot with finger. To flick at same spot on abdomen. Oh, that's too complicated, I think.
This is position for splenic rupture.
I have never seen that. I have never read about that, and I have never heard from anyone who's using. Because for free fluid only, you need to spend 5 minutes for one sign. That's a lot. And if patient is young and healthy, okay. If patient is ill, sick, you cannot do that. Can you imagine patient on knees and elbows?
But I thought that in this position we can do.
For splenic rupture, I don't think it's suitable to check it for 5 minutes. This sign.
I think that patient have suitable position. This one.
For splenic rupture, patient will sit down like that. You try to make him again, he will elevate.
In splenic rupture.
Because of irradiation to the left shoulder.
Demonstrate करो.
Okay, so palpation. We start with one hand while you're talking, getting history. Let patient be acquainted with your hand and don't start deep palpation immediately because it must be gentle, it must be with the whole surface of your palm and you do it gently like that. Main aim of superficial palpation is detection of tenderness, rigidity or guarding, and maybe you will be able to find some mass, aortic aneurysm or cecal tumor like that, big,
Superficial.
superficial, yes. Sometimes you are able to detect it with superficial. You don't need deep. Or like pregnancy.
If pulsation is present, we can.
For 7 weeks or 7 months of pregnancy, you don't need any deep palpation. You do superficial. Yes. So and you go checking all parts of abdomen, umbilical, also like that or like that, doesn't matter. But hold a little bit gently, and you ask is it painful or not, and you assess guardian. You can also compare right and left side with both of the hands. Sometimes you feel a difference. Spleen. Spleen, if it is enlarged a lot, usually it's palpable without any difficulties. So sometimes you are able, if like in case of leukemia or increased in some tropical diseases, it's palpable,
Malaria, like malaria.
just palpable with your hand without any changing of position. But if you want to palpate, so normal spleen is not palpable.
Yes.
Not palpable. If you do laparoscopy, sometimes you don't see it at all. So you need to change position. Maybe you will see, maybe not. But you have to turn patient on the right. Yes. And first you have to detect it with percussion. So you find this is 12th, this is 11th rib, okay? And from the
Posterior.
Axillary.
mid-axillary or posterior axillary, so you just find the point and then you do it along the rib, and you do it longitudinally. So this is beginning of the dullness. Maybe end, but this is too big for normal spleen. So normal spleen, it's difficult because if patient is not a child thin within wall like that, maybe it's so. I really do not trust this kind of percussion. So we cannot detect exactly. And for palpation, you place your hand here. You use your left for maybe like that, maybe not forbidden, but traditionally you use left one, and you go
Hooking. Deep hook.
deep under the costal arc, but it's
Painful.
Some patients will allow you do it. Some will allow you do it once only. You do it once and you will never go back. Yes. Some will not allow you from the beginning, like here. We are not able to do it here, but edge is not palpable here. So if it's here, you cannot reach it. Normal spleen is not palpable.
And so sigmoid column.
Sigmoid column. So you find spine. Yes. You have to make a fold. Then you go deeply, like that. So this is the direction of your palpation. Sometimes sigmoid column is, and of course it's better to look how patient is breathing. Inspiration here, expiration. When patient is expiring, all the muscle are relaxed. A little bit, but relaxed. So we do it during expiration. So inspiration and expiration. Usually sigmoid column is palpable, cecum is palpable, transverse column maybe, greater curvature sometimes, but never. Appendix, never. Pylorus, never. Duodenum, and some other places that maybe you can read about that in books, but in real life, if you find pylorus, I think you find the rectus muscle. Maybe pylorus is palpable if patient has tumor like a fist. Yes, it will be palpable. But if you have ever been inside doing laparotomy, if you have ever tried to palpate pylorus, you know that you cannot find it with simple palpation. Never. No. And appendix is the same. It's very thin. It's soft. So it's maybe inflamed appendix or with tumor in patient like that, for example. Maybe. But here in this abdomen, we are not able.
How can we find appendix?
Palpation of aorta. Aorta. Why do you need palpation of aorta? If you want to count heart rate or pulse, then you have more. For dissection, you never palpate aorta because if you do it strongly, you can cause rupture. Yes. In case of aneurysm, you just put your hand and wait for several seconds, and you will feel pulsating mass. And you can also do auscultation of the murmur inside the aneurysm. So you don't need real deep palpation. Deep palpation may cause rupture. So it's forbidden to do deep palpation of aorta. You can palpate sometimes, or you know this maneuver that during hot arrest, maybe during laparotomy, for example, while one surgeon is doing resuscitation, second may press abdominal aorta like that, with whole straight arm, and you press like that. So you do pressure of the aorta, you exclude lower extremities from the blood flow, and you concentrate all the pressure in the organs that really need it now.